they will actually, the NIH missed them a lot because the NIH does not factor for dizziness. It does not look at vertebrovascular injury.
Are those the only symptoms that they can present with?
No, sometimes they can have pupillary changes. They can have difficulty swallowing. They can actually have severe dysarthria. They can have weakness on one side of the face. They can have anything in anything in the cranial nerve distribution. They can have, because remember your cranial nerves, all of them except 1 and 2 are in the brainstem. Okay. If it's in the pons, what they will have, they can have myotic pupils. They'll have really tiny pupils. Pons, pinpoint. I want you to remember that. Pons, pinpoint. If you hear pinpoint pupils, think pons. Okay. All right. Alejandro. Yes.
Okay, injury to the extrapyramidal motor system does not cause paralysis or voluntary movement and general spasticity. Explain why and discuss the major motor symptoms seen in extrapyramidal motor disorder.
This is like a really hard one.
Practice within the spinal cord, right?
Well, extra, it's like involuntary, is like controls.
Involuntary spastic.
Uh-huh.
It like controls your voluntary, you're like shaky or.
Like
So what controls involuntary motor?
The no, it's the cerebellum.
Like the caudate.
Yes,
Caudate.
that's the basa ganglia. The basa ganglia. These are your extrapyramidal. These are your non-voluntary control. Your Parkinson's is implicated in this. Your Huntington's is implicated in this. Okay? These are your basa ganglia. And this, huh?
Effects of antipsychoticals.
Yes, extra antipsychotics cause it, and we're going to talk about it in pharmacology because antipsychotics block dopamine. If you block dopamine, then acetylcholine at the neuromuscular junction or at the nerve junctions in the brain go haywire, and there's no dampening effect of dopamine, so you get those.
tardive dyskinesia.
Exactly, all those movements that we don't want, and we can't control them. Okay? Yes. All right? It wasn't that hard, wasn't it? It looked hard, it sounded hard, but it wasn't. So, Alejandro.
Professor Bill.
Alejandro, come on.
The extrapyramidal motor system includes all motor pathways in the brain and brainstem that are no part of the corticospinal and
Pyramidal.
motor pathway. This system includes the basal ganglia, reticular formation, and part of the cerebellum. Disorders are classified as either basal ganglia motor or cerebellar motor symptoms. Both are characterized by little or not paralysis of voluntary movement, normal or slightly increased tendon reflex, presence of tremor, chorea, atostosis, and dystonia, and rigidity of the intermittent rigidity. Muscle tone and equilibrium are also affected.
Okay. So rigidity, spasticity, what do you see? Your Parkinson's patients, they shuffle like this. If you try to move their arms, it goes like this. Usually, if you're, yeah. When you go like with Parkinson's, how you assess them, you'll see them if you're in a neurology office, when you graduate, stop being so stiff. The neurologist usually take their arm and does this, okay? Cogwheeling. And usually with the Parkinson patient, they'll go like that and they'll stop. It'll be like a doll hand. It stops all the way around, okay? And that's cogwheeling.
Also, the Huntington does that. The Huntington's people.
Huntington's is like a dancing chorea type movement. They usually do like this.
Yeah.
Your hands are like that, and their legs when they try to walk is like that.
Yeah.
It's like a chorea type movement. It's like almost like a
Yeah.
dance. And you get this hemiballismus in like anterior ACOM strokes in the middle of the brain. Remember the homunculus man where his foot is? If you have a stroke in that same area, they can have this hemiballismus where they do this with their leg. Like that. It's rare, but they do it. It's a dancing movement. Did you see it? I can't call on him again, he'll have a heart attack. Early.
68 years old woman presents due to memory loss and confusion. Her daughter reports progressive decline in cognitive function over the past year. She has recently become unable to take care of herself. She has become withdrawn and has no interest in her usual activities, such as gardening and reading. She has always been a fastidious housekeeper. However, recently she's noted to have been wearing the same clothes for several days, and her house is unkept and dirty. She seems anxious and confused, and she calls her daughter several times per day, worried that the neighbors, previously her good friends, were spying on her. She denies any bowel or bladder incontinence, headache, or gait instability. Overall, patient has been healthy.
Hold on 1 second. Why is it important that this question tells you that there is no bowel or bladder incontinence or gait instability?
Because it's not a stroke or it's not a tumor in an area.
Voluntary.
Now, I know Dr. Leal talked about it. I think she did. When we talk about hydrocephalus, normal pressure hydrocephalus is characterized by bladder incontinence, gait instability, and confusion. And if they get diagnosed a lot with dementia when it's normal pressure hydrocephalus, okay? The 3 W's, wacky, wobbly, wet. Wacky, confused, wobbly, they wobble when they walk, wet, they're incontinent. It's normal pressure hydrocephalus. If the family says, she's been fine, all of a sudden, progressively she's been getting confused, and I noticed that she's been falling a lot, she can't walk straight, and now she's peeing on herself. Wacky, wobbly, wet. Normal pressure hydrocephalus, you have to evaluate for that. It's an idiopathic type of hydrocephalus where the ventricles get usually large and CSF builds up inside and they have increased pressure. It's not really high pressure, but it's increased pressure, and they end up with those symptoms. Wacky, wobbly, wet. Okay? So that's very important to mention that she doesn't have any of those, so you're going to exclude normal pressure hydrocephalus up front. Okay? Go ahead. Sorry.
No, that's fine. She does have a medical history significant for hypertension, for which she takes hydrochlorothiazide. Her history is negative for tobacco, ETOH, or illicit drug use. On physical exam, her vital signs are within normal limit. She's well nourished, well developed with a flat affect. She's oriented to person and place, but is confused to time and event. Cardiovascular, pulmonary, and GI exam within normal limit. Neuro exam within normal limit, CN 2 and 11 intact. Motor exam within normal
12,
limit.
2 to 12, sorry.
2 to 12.
It should have been 2 to 12. I forgot an one.
cerebral exam with a normal limit.
Mini mental exam, the mini mental, scale exam.
24/30.
Okay. What's the most likely diagnosis? Huh? Dementia. Definitely dementia. It's not normal pressure hydrocephalus. She has a progressive, altered mental status. Usually they get paranoid, like, I'm not sure why. Most people get paranoid. Most people will tell you that unless they're really nice, pleasant dementia, I think I'm gonna be one of those aggressive dementia people because my personality says it. And I'm like, oh my God, I hope I never get dementia because I'm gonna be one of those people that you tie up in the bed when you go to the hospital. I'm gonna be like those people who's gonna tell you off about yourself just because I'm just like, that's my personality now. I see all those nice dementia patients who are so sweet, and I'm like, I wish I would be that, but I'm not gonna be that person.
Hopefully you're not
Huh?
gonna get it. Or we take a medication.
You give me some medication. Just give me magnesium. Alright, but seriously, they're usually just like hyper vigilant. They just think everybody trying to get them.
There was a patient on our unit that she was like not early in dementia.
Mm-hmm.
So it was nighttime. Her telemonitor was going off and to go and change the leads. Her nurse went into the room and he couldn't get into the room. She had put the bedside table in front of the door.
Oh my God.
So when he came in, he doesn't speak Spanish, Spanish-speaking patient. And I asked, hello, I'm your nurse, I'm coming in to check on you, whatever. So he goes, he fixes the leads and leaves. And then the tech goes into the room to check on the patient again because the telemonitor lead's going on. And the night set, like the actual table, like the night table was in front of the door, not just the bedside table. So she's like having difficulty opening the door. And when she asks the patient why she did all that, she goes, some Filipino man is coming into my room, trying to take my wallet. He's trying to harm me, touching me. And he explained to her, he's like, I'm just checking your monitor. She had no idea and he didn't know that she was that confused.
Wow.
Some Filipino man came, took my wallet, left me like this, so I put that to protect myself. And we're rolling on the floor laughing.
Yeah, that would be me. I'll be that person. Yes.
It's really sad.
All right. So what's your diagnostic test? You already did the mini mental exam. That's basically what they're gonna do. What else? You can do a CT, just a CT, because she could have had a slow growing tumor. She could have had a meningioma that's slow growing. You want to make sure that you have normal imaging. And then what do you treat her with? All the anti-dementia, anticholinergics, or Aricept, or your NDMA inhibitors, your dementia.
How do their CAT scans look?
Normal. But you see atrophy. Some people, like this one, the frontal temporal dementia, they used to call it Pick's disease. Usually it's a younger person, after age 35, before 75. But when you look at their scan, I actually have one. I wonder why I didn't put that picture in there. I'll have to find it. Their brain, all the frontal lobe eats away. And they end up with no frontal lobe. So when you look at the MRI or the CAT scan, you see no frontal lobe. They have a slow degeneration of the frontal lobe, and it starts in a young generation. They have no idea what causes it. They're just trying to, they're starting now to, they do ask people to donate their brain for autopsy. My last patient that I had that had this, the family did donate her brain to science to test to see what causes it. But this frontal lobe dementia, Pick's disease, it's an early age. This lady was in her early 40s. She had like a 12-year-old little boy.
What's the prognosis on, like?
They die.
Bad. That's bad.
They die. They usually lose their whole frontal lobe. They can't walk. They usually die from respiratory issues. They usually die. Lewy body dementia is what we usually see a lot now. They don't know the Lewy bodies, like little plaque tangles that are in the brain. Vascular dementia, someone who's had multiple strokes, they lose different parts of their brain, end up with a vascular type of dementia. Hypertension can do it, diabetes can do it, they can get a whole lot of lacuna infarcts, a lot of infarcts in the brain will give it. And Alzheimer's disease is the one we know of. Creutzfeldt-Jakob is another type of infectious type of disease that you have. It causes a dementia. They don't know exactly, there are different types of it, different variants, but it's a prion. It's a prion disease, and the prion you cannot kill. It's like mad cow. It's just one variant of Creutzfeldt-Jakob. And usually if they have that prion, nothing you do will kill it. Nothing. So usually what happens with these patients, you cannot take them to the OR to get a biopsy, because if you take them to the OR and get a biopsy, you have to throw away the entire OR. Because none of those instruments or anything in that OR can touch another patient, or you'll give it to them. So usually these patients are diagnosed post-mortem. There are diagnoses of exclusion. There are some labs that they can do, some rare labs that they can do that points to it, but there's no set specific diagnosis.
What you call that, prion?
It's a prion, yeah. You can't kill a prion. Okay. So you have Alzheimer's, dementia from Lewy bodies, frontotemporal dementia. Again, frontotemporal dementia, because you're losing your frontal lobe, executive function, personality, all these things are what usually goes first. A lot of times you see these patients, they just have this flat affect. They can't interact with you, they don't interact, they don't do anything, and usually they die very early. In the 30s, as early as the 30s, this lady that I took care of, she was diagnosed in her late 30s. That is devastating, okay? And she died in her early 40s. A young woman with her little kid. It's just very hard to see. Again, depression, multiple sclerosis. Let me give it to you. Anna, you're sitting over there in that corner so quiet. This is yours.
1 year ago, a 24-year-old female had an episode of hypothermia for 2 weeks. The symptoms resolved completely. Currently, she complains of left arm weakness but no headache. Which of these is most likely the diagnosis?
What's the diagnosis? MS. Why are we saying it's MS? So usually the first time they come in, they usually come in with some ocular type symptoms. MS you cannot diagnose just on one occasion. The way you diagnose it, McDonald's criteria says that you have to diagnose in space and time. So if the person comes in on the first initial visit and they have a lesion, one lesion, and that one lesion is in the retina, okay? Let's say they have one lesion there, and they come in with some visual disturbances, and you scan them and you're thinking, this is probably MS. You cannot diagnose this because there's only one lesion on only one time. Now let's say this other person comes in, they come in with visual disturbance and weakness on the right arm. You scan them, they have a lesion in the brain and a lesion in the thoracic spine. You can diagnose them even though it's the first time because they have a lesion in different space, one here and one here. Let's say now that you have a patient that comes in like this patient, 1 month ago, they come in with a visual lesion, and the next month they come in with weakness on one side of the body. But now they're two separate lesions, two separate times, you can diagnose them. Okay? So if it's the first time, they have to have more than one lesion for you to diagnose them.
Do those lesions stay there?
McDonald's criteria.
Do they stay there, those lesions?
The MS lesions?
Yes.
They do, kind of, sort of, but they heal over. The inflammation goes away.
Because they have like exacerbations, I guess.
Well, the exacerbation is basically they have more lesions or lesions occur. They give them the steroids, the corticosteroids. They can actually give them those not DMARDs, but yeah, kind of DMARDs. They're the methotrexate, they can give them those, and they,
Immunosuppressant.
huh?
Immunosuppressant.
Immunosuppressants, they can
But,
give them those.
my
And
question.
they usually it usually, takes the inflammation away, so the, symptoms go away. Some people stay with symptoms, the same symptoms for forever, but they improve, but they can stay with them. This is what your MS lesions look like. Remember, you have your neuron, and then you have your axon. Your axons are covered by myelin, okay? Your myelin sheet is what usually is disrupted, and you have dismiss, or inability to transmit signals. Different neuromuscular disease processes. Okay, myasthenia gravis. How do you diagnose myasthenia gravis? Usually these patients come in with one symptom.
Muscle weakness.
Muscle weakness, yes, but myasthenia gravis, what do they come in with first? Ptosis. Usually ptosis is the first symptom that they come in with. I was waiting for somebody to say ptosis.
I wanted to say it, but I didn't want to bother you. Just too well, you want to say it.
Usually come in with ptosis, and usually what is myasthenia gravis? It is a breakdown of acetylcholine at the neuromuscular junction, okay? So you have acetylcholinesterase, what actually is an enzyme that breaks down acetylcholine at the neuromuscular junction. And usually, if you don't have acetylcholine at the neuromuscular junction, you can't transmit the nerve impulses to make the muscles move, okay? So when you have a breakdown at the neuromuscular junction, that's usually when they have weakness. Patients usually go to bed, they wake up, and they have movement. Progressively throughout the day is when they start getting weaker and weaker and weaker and weaker. Yeah, I have a friend who has myasthenia gravis, and when she first got diagnosed, she was waking up every morning and fine, and then in the day, her eyes would be closing. So out of curiosity, I don't know why sometimes your friends call you to tell you the dumbest things, but when they're supposed to call you to tell you stuff, they don't really. So she called me to tell me something else, and she said, by the way, I'm having this issue. I'm not sure what it is, but I have to hold my eyes open a lot, and it keeps closing down, and I haven't even been able to go to work because I go to work, and then by the end of the day, I have to hold my eyes. I can't drive home, and then I'm driving home, and I'm holding my eyes open to see, and I'm like, huh? So she was like, yeah, and I went to the doctor, and they did an MRI, and they said I don't have a brain tumor, because at first they thought I had a brain tumor, but I don't know what's going on, because it's getting worse, because now by like 4 o'clock I can't see. So I said, you have myasthenia gravis? She was like, no. I'm like, yes. I was like, tomorrow morning, I want you to do me a favor. I want you to take a picture as soon as you wake up. I need you to take one at 10, I need you to take one at 12, I need you to take one at 2, I need you to take one at 4, I need you to take one at 5 and 6. And I need you to send me all the pictures. As soon as you take them, send them to me. Sure enough, by 6 o'clock, she couldn't open her eyes.
What test do you do to the patient?
Tensilon test. You give them acetylcholine. If they get better, it's myasthenia gravis.
So, what is the
Hypertrophy.
how does it work?
IVIG.
IVIG, how does it work?
Remember, you're giving them immunoglobulin, so you're actually giving stuff to help your body fight.
Yeah, I was reading about it, but I wanted to listen for it. So you give them IG to kind of revitalize
The immune system.
the immune system.
To stop the immune system from attacking itself. Because remember, these are autoimmune diseases. Right? All right, we're almost done, I promise.
That's good.
Kim,
Yes, again, okay. 37-year-old male
I know you guys
presented to
get
a
tired of reading, but.
That's okay, never mind. Presented to a chiropractic office complaining about recent onset of tingling and numbness in both hands. He also complained about his feet, which he described as feeling sleepy. His symptoms began slowing following an upper respiratory tract infection that he had about 14 days ago. No history of trauma was reported, nor had he ever complained of the current symptoms. He had a past history of mechanical back pain and received treatment including spinal manipulative therapy, I hate chiropractors,
Me too.
which gave them complete relief. Yeah, right. Examination revealed a healthy person in otherwise good condition. Generalized weakness of the lower extremities is noted. When testing the quadriceps, hamstrings, and gluteus
Gastrocnemius,
gastrocnemius soleus muscle, sensory loss was variable in both hands and feet. The tendon reflexes, upper and lower, were 1+. A general physical exam gave no other orthopedic, neurologic, or organic findings. Respiratory and cardiac function was within normal limits.
Okay, so he has a symmetrical weakness that started after he had a virus. Possible Guillain-Barré. How are we gonna diagnose this?
Cerebrospinal fluid.
Cerebrospinal fluid, and what are we looking for in the cerebrospinal fluid? Protein without white blood cells. You're looking at symptoms and the CSF. And the CSF has protein without white blood cells, and the person has asymmetrical, is a symmetrical weakness. I was saying asymmetrical, but I said asymmetrical, so I realized I
From
said
bottom
that.
to top, right?
Symmetrical weakness, that starts from bottom to top going up. Ascending. Symmetrical weakness. I'm not even going there, but there's several variants that can start in other places, but usually traditionally, you'll have a, descending symmetrical weakness, symmetrical weakness. Starts from the feet, go all the way up. You wanna worry really, a lot because you can impact the diaphragm. And if you have decreased diaphragmatic excursion, you can have respiratory arrest, okay? Those people, you will measure their, peak flow, your vital capacities, and you're gonna make sure that they are breathing well, able to take a deep breath. Usually it's a virus. Usually the patient has an episode of a virus, maybe like 2 weeks before. It can be gastrointestinal, or upper respiratory infection. And what usually happens is that your body has this exacerbated immune response to that virus.
Professor, multiple sclerosis also is treated by a viral infection, right?
No. Multiple sclerosis is something completely different. And it's autoimmune. Your body you have this predisposition and your body just attack itself.
They don't know what causes it, it's just your body.
Multiple sclerosis, they still don't have a
Triggered.
definitive, no. Hereditary, they're still saying that there's some environmental factors, but they can't isolate them.
I have 2 female cousins on the same side of my family. They're both in their 30s when they were first diagnosed with MS, but completely different. One is relatively healthy, can't take new medications. The other one is now went from walking to having to use one of those hover things
Yeah.
that she can't walk.
I have a good friend that actually had to move out of Florida because they
Because of the
the heat here can get them overheated and they can do really, really horrible here. So she moved to, I think, Maine.
Sounds cold. Jersey.
Jersey?
Is it Jen?
No, somebody else, but Jen too. Jen moved here from back.
Jen move out?
Huh?
Jen?
Huh?
The girl that is talking about the speech therapy? No.
No. Mavis. I call you, Joanna today.
Mel is a 40-year-old female who admitted to the ICU after a
Hunt sorry.
okay,
2.
2.
Hunting has 2. That's how you score subarachnoid hemorrhages.
Oh, okay.
Sorry. I was getting tired.
I see. 2 subarachnoid hemorrhage 24 hours ago. She went for cerebral angiogram and was found to have a rupture of a large right MCA bifurcation aneurysm. She is
Status post.
coiled embolization of the aneurysm. immediately chose the first post-op. She was awake, alert, oriented, and poor. However, over the last hour, she has gotten sleepy and she is not answering to her name call. You order a SAT CT of the brain, which shows enlarged ventricular system.
Okay, so what's her diagnosis? Hydrocephalus. Okay, so I know Dr. Leal talked about these. You have communicating versus non-communicating. Communicating hydrocephalus, everything is open and there's adequate flow of CSF. Non-communicating means that there's an obstruction somewhere. In subarachnoid hemorrhages, where are the arachnoid villi? In the subarachnoid space. What do the arachnoid villi do? Reabsorb CSF. So we said that CSF is made in the brain at 25 mLs an hour every hour. It must be reabsorbed at the same rate. What the blood does, if you have meningitis, if you have a subarachnoid hemorrhage, is that it actually covers the arachnoid villi. So CSF cannot be actively reabsorbed. So what happens is the brain keeps making CSF, but there's no reabsorption. So you end up having hydrocephalus, a communicating hydrocephalus, because there's no blockage. So everything is open, it's communicating hydrocephalus. Subarachnoid hemorrhage, meningitis, anything that clogs the arachnoid villi is a communicating hydrocephalus. Normal pressure hydrocephalus is also a communicating hydrocephalus, but it's not due to clogging of the arachnoid villi, it's idiopathic. So we talked about normal pressure hydrocephalus when we said wacky wobbly whack, dilation of the ventricular system. We don't know why. They end up with a dementia type episode or dementia type appearance. We talked about subarachnoid hemorrhage or meningitis with pus or blood covering the arachnoid villi. That will also give you a communicating hydrocephalus. Now a non-communicating hydrocephalus would be something like the Sylvian fissure. The Sylvian fissure, or the aqueduct of Sylvius, I'm sorry. Aqueduct of Sylvius is shaped like this. It's like long and skinny. So it actually is very easy to be blocked. So sometimes if you have an infection, piece of the like debris can actually go in there and clog that. Once you have an obstruction, aqueduct of Sylvius is one of the major places you'll see it. You can actually have a non-communicating hydrocephalus. It can be the foramen of Monroe, it can be at the aqueduct of Sylvius, it could be at the fourth ventricle, it could be at the third ventricle, the fourth ventricle, any one of these. At the third or fourth ventricle, what usually obstructs them is blood. If you have a basoganglionic hemorrhage, it will go over and it can actually cause a clot there and obstruct the fourth ventricle or the third ventricle. But usually if there's a clot, it's a non-communicating. If there's a